Okay, welcome everybody. Thank you so much for being here with us this afternoon. My name is Katie Earle. I'm the coordinator of the University Express program, and I work for the Erie County Department of Senior Services. And we're joined here today with Thane Schulz from ECMC. We're very excited to have him on this topic, which is important nowadays. It's always been important, but especially now. So before we get into his presentation, we'll just go over my basic housekeeping things, because as always, we have some new folks on. You just heard me say that we're recording this, and I will try to post it on our website in the near future. And second of all, there are other people on with us today. You might think that you're the only one, but I promise you there are others. It's just that we're in an anonymous participation mode, so only Thane and I can see everyone who's in here, or your names at least. And you've also joined without your video showing, and you're muted, and you can't do anything about that. It's not because you've done anything wrong. Those are just the settings for our program here today. So throughout Thane's presentation, if you have any questions or comments, please go ahead and type those in the Q&A, and we'll try to field those throughout his presentation, and then the questions at the end, as many as that we have time for. So if you're new, you find your Q&A panel likely on the right-hand side of your screen when you join from a computer or laptop. It popped up. You may just have to hit that caret to expand it. You'll see the text box, and you can send your questions to me. You also can find that likely in the lower right-hand corner of your WebEx screen. You'll see a box with a question mark in it. That's your Q&A. And then if you're on a tablet or smartphone, you can poke or touch your screen. That'll bring up your control panel. And then you click on the circle that has 3 dots. You'll see Q&A, and then you'll be able to access it. So we do hope you participate here with us today, and we hope you get a lot out of this presentation. I would like to thank the sponsors of our program, which is my Department of Senior Services, Blue Cross Blue Shield of Western New York, Excelsior Orthopedics, and Wegmans for everything they do to make this program possible. And we at Senior Services are here if you have questions about programs, services, or benefits. Again, even if you don't know where to start, we're a great place to start. So we're at 858-8526, and I'm going to introduce our speaker. Thane is a licensed master social worker at Erie County Medical Center, providing palliative care on a multidisciplinary team for seriously ill patients, both in the hospital and through their transition home. He is a certified care manager and holds an advanced certification in hospice and palliative care. His training at the University of Buffalo focused on trauma-informed approach to caring, and his experience not only in a level 1 trauma hospital has demonstrated that patients and families respond well to this treatment modality. Thane has many years of providing home care services to patients and families with cognitive and physical impairment prior to working at ECMC, which prepared him to design a transitions of care programs to help ensure that patients discharging home have all the tools and resources to help them home and stay safe instead of back in the hospital. He is a field educator for the University of Buffalo School of Social Work, member of the National Association of Social Workers, and enjoys training future generations of social workers. So Thane, thank you for being here today. I will unmute you and mute myself. Take it away.
Thanks so much, Kate. I appreciate it. Thank you to everybody who's tuned in to watch. I went into social work, not IT, so if I do anything wrong, I apologize. And I wanted to say how much I appreciate the University Express and how well you've done, Kate, organizing even so that we can have this during a pandemic. So I appreciate the opportunity and the intro. So I've been interested in trauma and trauma-informed care for quite some time. I have, some friends who were victim accidents and accident victims. So, for a long time, sort of been on my mind about how it's those experiences have affected my friends and some of my family, specifically with traumatic brain injuries, spinal cord injuries, or in the case of some older folks who had some sort of a stroke, like a cerebral vascular accident, something like that, that has caused damage or impairment, and seeing how that affects their lives and those around them. So I'm just going to kind of start with my slide deck here. If it will let me, hang on. There we go. Okay, so basically the objectives that I had in mind were really kind of to take you into ECMC a little bit. So what is trauma? How does it impact someone's life? And what types of trauma are there? Who does it impact? So like what's its prevalence? How is it identified? screening interventions and things like that. Perspective from ECMC, we're a level 1 trauma center here in Buffalo. And, you know, I'm a bit biased with trauma-informed care because that's what, you know, they drill into our brains in UB's social work, and also, you know, providing palliative medicine here at the hospital. So I'm going to kind of give you a little bit of a twist on how we operate here. And I hope that that's actually going to give you a frame of mind so that if you do have a loved one who's in the hospital or you're here after a trauma, which I hope never happens, so that you have some understanding of how you can advocate for yourself or your loved one when they're in the hospital. And then I have a sort of a case example that I want to run by you that was my experience, my first experience in home care, that really opened my eyes to the importance of trauma-informed care, how to do it. I mean, they train you, obviously. We learn in the academic setting, of course, but when you see firsthand, it really clicks. And that's why we have such comprehensive field education. So SAMHSA is the Substance Abuse, Mental Health, and Services Administration. They offer lots of training. They're pretty much the gold standard for substance abuse and for mental health and things like that. So I wanted to use their definition of trauma. So traumas defined, they identify trauma as individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So I'm going to plug palliative care, which is what I do here at ECMC, because there are a couple principles of a trauma-informed care. First one is to reduce suffering, palliative care, excuse me, to reduce suffering. So anything that we can do to support the family or patient that's going to help eliminate extra stress, undue burden, things like that, and to improve the patient's mental health, spiritual well-being, psychological, physical, mental, everything. And so it's palliative care is intrinsically trauma-informed. So I'm obviously sharing my bias here, which I hope is okay because I'm doing it. These are the most commonly reported traumas. So death of a loved one, we see that a lot here with palliative care, because we do actually provide end-of-life care while here in the hospital. And we work with hospice quite a bit to help patients who want to spend the time that they have left at home. Witnessing violence to others or experiencing interpersonal violence. So in the United States, about 61% of men and 51% of women have experienced one trauma in their lifetime. And then, so this one's a little bit trickier to break down because it identifies, so if you look at your screen, the 39% of men, that's the percentage of men who have not actually had a trauma. So then if you break down the people who have, 26% of them have had one event. 2 is 15, Kate's in my way here, so 10% for 3 and then 10% for 4. And then on the, for women, it's 49% have not had an experience, 26 with 1, and then thankfully it goes down as you have more and more. So why would this be? If you think about the prevalence of PTSD, the rates might range from 51 to 61%, but for some groups, it could be 30% to 58% for groups that have a higher risk. So having more trauma experience or traumas or traumatic experiences for those smaller groups of folks who are, I would say, for example, survivors of natural disasters or veterans. There's an interesting and very well-known study called the ACEs study. So it's a Adverse Childhood Experiences study. So this looks at the different types of problems or traumas that a child might have. So of course, child abuse, neglect, substance use, or mental illness of a family member. So if you have a parent who is, a drinker or using recreational drugs and things like that, then, there's a likelihood that there might be either physical abuse, substance abuse with the child as they grow older, or, any kind of financial issues that could be traumatic for the patient. And sometimes, the parent's going to be experiencing violence themselves. And so that when you're a child and you're seeing trauma to one of your loved ones, that's going to be very difficult as well. So disasters, these are like mass traumas. So these are hurricanes, earthquakes, chemical spills and explosions, terrorist attacks. Think about how 9/11 actually, so it obviously had a physical impact on everyone who is in New York and an emotional toll on the entire country and many of our friends in the world. So that was one event, think about the lasting consequences that has had on the survivors, the loved ones of those who we lost. So that's why we come up with rituals, things like that, to honor those who we've lost and to allow ourselves to process and think about what those people meant to us. And that's why those sort of rituals, that's why we have funerals, that's why we have other ways to honor the ones that we've lost. So there's, of course, domestic violence, which is sometimes intimate partner violence, so physical abuse, sexual abuse, psychological abuse, and financial abuse as well. And so then also, veterans, prisoners of war, refugee groups, and then, so historical trauma, this is a little bit difficult for people to kind of understand because the science has not really been established to be understandable, to be fair. It's epigenetics and it gets very complicated when you're reading about it. But basically what they're theorizing is that people who have experienced historical trauma, such as Holocaust, I think the Native Americans are a wonderful example of this. Those who've experienced slavery, those repeated historical traumas over a lifetime or generations changes the genetic makeup of those families that are the descendants of their loved ones. And so what that does is it really impacts what we consider to be resiliency. And I'm going to get to that in a little bit, but I think that historical trauma really explains a good bit of why we see some inequities in resilience, inequities in socioeconomic status, and social determinants of health. So can keep that in the back of your mind. So these are risk factors. I was just talking about lower socioeconomic status, obviously, for trauma, not just historical trauma, but any kind of trauma. Race, ethnicity, gender, lower social supports, behavioral health disorders, trauma history, and then the intensity of your reaction to a traumatic experience actually makes you more or less at risk for secondary or tertiary exposure. And then, so these are protective factors. So what we think about when something is more likely to cause an accident or cause a trauma, that's a risk factor. And something that's more likely to prevent us from having that exposure or having that experience, those are called protective factors. So things like self-esteem, resourcefulness, problem-solving skills, these are kind of what contribute to resilience as well. So think about that. And there is a theory in psychology called attachment theory. And this is kind of fascinating to me because I see it here in the hospital quite a bit. So basically, it's between, relationships. So if you have a good example is if you have a child being raised by a parent, there are different types of raising that child so that their experience of learning and failing are different. So parents who actually establish a secure attachment with their progeny, their child, they bolster the confidence of that child so that they're able to go and explore and fail or do well. And when they fail, they can come back and they're comforted and nurtured by their caregiver. An insecure attachment is when they do not establish that sense of independence and that sense of ability to fail. And so they wind up needing to have constant supervision. They need to get constant reassurance. They don't have that ability to go out and be independent. And so interesting, what I see here as far as attachment theory isn't with children necessarily, but it's with partners or between spouses and things like that. So when we have a patient who is dying, and one of the things that I assess is, what was their attachment like? Was it a secure attachment? Because if it was, it's going to be an indicator to me that the surviving spouse or loved one will actually do better with grieving and recovery for a longer period of time. If it's an insecure attachment, it means that really this couple has never really been able to spend time apart or be independent or do their own activities. So like their entire lives are revolving around that relationship with the family. And, I'm not saying that one is better than another. I'm just observing and reporting really that I have found that people who have developed secure attachments with loved ones wind up having better health outcomes and better outcomes in the grief process. So there's other protective factors, sense of humor, optimism, feeling a safety or sense of control. That's very important because that's something that you can establish for yourself, and that's something that can be worked on with others. And then religion, affiliation, or spirituality is also very important. Quality of life and functioning. So trauma itself may actually result in physical injury. Obviously, PTSD is associated with worse physical health. People with PTSD may face challenges in self-care. Strained relationships or strained family relationships may accompany familiar trauma histories. An individual's ability to utilize resources can be negatively impacted by trauma, obviously, and then with higher rates of unemployment and work-related problems. So resiliency is sort of something that you learn as a child, especially if you have a secure attachment. It's something that can be taught, and there are some intrinsic characteristics that some people, and there's not much science behind this, but some people have an innate sense of being resilient more than others. So when we are talking about trying to learn to be resilient, there's these principles. So being able to cultivate a belief in your own ability to cope. So if you have a belief that you're going to be okay, and this is what I see with secure attachments and a death of a spouse, is that they're able to think about, how am I processing this loss? How am I going to take care of my own emotional set of feelings? And how am I going to prevent myself from falling into a sense of despair or hopelessness? So they can actually develop a plan. And so you stay connected with sources of support. So a lot of people may turn to substances, things like that, to support, especially with insecure attachments. People who are developing or have an innate sense of resiliency, they cling to their support system because it helps make them stronger. So talk about what's going on. Be helpful to others, because that's, I think, a characteristic that brings out joy and happiness of people. Activate positive emotions. Cultivate an attitude of survivorship, and seek meaning in your life. So these are other disorders that are linked possibly to trauma. So mood and anxiety disorders, personality disorders, impulse control, eating and substance abuse disorders, and of course, serious mental illness. So this is something that's important to understand. So the impact of trauma, if you think back to that ACEs study, the children study, when children went through poor experiences that were either traumatic or negative, it literally disrupted their neurodevelopment. They were not able to develop attachments. They weren't able to develop skill sets. Their brains didn't develop as quickly or at the same, at the same rate as their peers. So that's one of the impacts of trauma. Social, emotional, cognitive impairment. I was saying earlier, people who have been experienced a trauma, they adopt health risks behaviors, so coping mechanisms like smoking, substance abuse, self-harm, sexual promiscuity, violence. So severe and persistent behavioral health, physical health, and chronic disease and social problems lead to an early death. So that's what we see with, and this is, exponential with the number of traumas the person has had or the severity of that trauma. So this is the impact of trauma. The next slide is the effects of trauma. So trauma changes, and I'll use the perspective here in the hospital, which is kind of what I want to give you context, what we think. So trauma changes the patient's perspective on medical decision making. And so this is interesting, and what I would like for you to take away from this, that patients who have experienced trauma may be suspicious of medical recommendations from providers. They may be anxious about medical procedures, which is very common to be anxious about going through something, especially if you don't know much about it or if you don't have experience with it. But this is very high anxiety, crippling anxiety, really, at times. Paranoid about medication. Sometimes the patient doesn't trust that the medication that's being given to them is the right one. It may not be familiar to them. They're afraid of caregivers, afraid of being alone, afraid of being touched, and feeling trapped or held against his or her will. And, there is the ability to leave against medical advice, but we try to encourage our patients to get the kind of care that will help them ultimately. And so we encourage them to stay and try to balance that without making them feel trapped. And then be, just like with medications, suspicious about food or drinks. So when a patient acts like this, there's a medical sort of phenomenon with non-compliance, and I don't like the term, but it is used pretty frequently. When someone is not being compliant with the treatment plan or with the medications or with the food or something like that, or they're leaving AMA. So this disrupts the proper distribution of healthcare, right? So that promotes inequity in receiving treatment if their patients have been traumatized at some earlier point, and being a trauma hospital, we have to consider this. So medical care can re-traumatize patients. If you think about this, it kind of makes sense, face value, removal of clothing, depending on what kind of trauma you've experienced, physical touch, personal or embarrassing questions. There is an inherent power dynamic between the caregiver and the patient, which we understand. Gender of the caregiver, vulnerability in physical positions, loss of and lack of privacy, having low sense of control or choice. Sorry about that. not asking permission before providing care, and the expectation that the patient trusts the caregiver. And these are important to think about, and I'll tell you why in a second. So the effects of trauma, there are different types. So if you think, I don't know, can you guys see my mouse? Oh, okay. So I've been sort of like scrolling all over the place, like a maniac. Okay. So childhood trauma can impact the brain structures, leading to multiple risk factors, including mental health and chronic health conditions. So there's childhood, and then there's ongoing, and then there's current trauma. So these kind of manifest in different ways. So ongoing trauma leads to cardiovascular, GI issues, endocrine and immune system problems, as well as exhaustion, sleep disorders. Is anybody experiencing any of this in the pandemic? I wonder. Substance abuse, depression, psychological issues. And, current trauma kind of manifests in physical ways, such as bruises, wounds, broken bones, brain injuries, others. So this is trauma-informed care, basically. So I think of this in sort of a sequential order. So if you think about, so there's safety, trustworthiness, choice, and collaboration. Those are sort of the pillars, four kind of pillar categories of what we do to ensure that someone is receiving trauma-informed care. So for example, safety. When a person comes into the hospital, it's our role, and this is really social work writ large, this is not just in the hospital, because you got to make sure that somebody feels safe. If you're a counselor or something like that, or if you work for CPS or APS, you've got to help that patient or that child feel safe, emotionally and physically. And then you have to, instead of expecting that patient or that client to trust you, you have to earn that trust, that trustworthiness. And once the patient feels safe and can trust the caregiver, then there's a choice, right? So what in the treatment, services, discharge, the right to refuse treatment. So once those sequentially are formed, then collaboration between patients, families, caregivers, those all come together and help the person feel empowered with their physical health, their emotional health, the treatments that they're receiving or refusing, and they feel that people are working together. So sometimes to think about what it means to be thinking in trauma-informed care, you have to ask the question, so what happened to the patient, not necessarily what's wrong. So it helps to reframe your bias, basically. So if somebody's being non-compliant, like I was talking about, you got to think about, well, so I'm not angry or frustrated with this patient because they're non-compliant. I'm not saying what's wrong with them. Something has happened to shape their world schema, the lens that they use to sort of understand and observe and make choices in what they're visualizing and conceptualizing in their environment and in their space. So we have to really think about how institutional settings are very complex organizations, and so they may have difficulty with the foundational premises of trauma-informed care. So collaboration in a large institutional setting can be challenging at times. Communication between the providers and the teams. ECMC is a large hospital, and we have a lot of different specialties, so we build relationships between caregivers, patients, providers, and that's critical to promote better health outcomes. So, like I was saying, non-compliant. So some patients with a history of trauma can be labeled as non-compliant or a problem patient. And, that's not an ECMC issue. That's a problem throughout all services and all healthcare throughout at least the United States. And so a trauma-informed approach trains the caregivers to assess for trauma, or potential human rights issues and avoids labeling the patient. So this is important because trauma victims, they may interact and engage in healthcare differently than others. So if a patient reports current or past trauma, it will help with caregiving by teaching caregivers how to respond, teaching them how to earn the patient's safety, make the patient feel safe, earn their trust. In institutions, knowing about the impact of trauma can improve patient outcomes. Knowing how to treat patients with trauma-informed care improves experience as a caregiver because you feel like you're taking care of the patient better. So there are a couple, this gets a little bit complicated with scoring. If anybody has questions about this, I can certainly answer, but so this is a PTSD checklist, C, so civilian. So there's a military and a civilian version of this, and also this one, which is the PCLC-6. So the first one is only 2 questions, which is basically what I use if I feel that I'm assessing, if I'm observing and seeing that there's some evidence of trauma, I'll go ahead and do this checklist with them. Feeling very upset when something reminded you of a stressful experience in the past. I'm actually doing a webinar. So can I talk to you in a second?
Yeah.
Okay, thanks, sorry. Repeated disturbing memories, thoughts, or stressful experience from the past. So if they answer quite high with those, then there's a likelihood of a trauma. And then the PCLC-6, that's if you think it might be a more severe experience with trauma. But this is how, we screen without an instrument. So an instrument is like a tool that we would use that, like the PCL-6 or the 2, that is standardized and it helps us to score the person's answers to us. And that helps us to provide treatment that's in line with what they want or what their experience has been. So, but there are ways to assess for it without an instrument. So patients who have unusual injuries, so contusions, lacerations, hematomas, ligament injuries, broken bones. So for example, this is your ulna right here. And so it's very unusual that people hurt themselves there because there are other ways that people naturally tend to fall if they're falling, if it's like a natural injury or accident. But usually if someone's doing this, it's called a nightstick injury because that the old school police, they would hit, you would defend yourself, right? And so it's unusual to have an injury here. So that's an indicator that there's trauma. Handprints, strangulation marks, cigarette burns. But then if you're not seeing physical injuries, then you might be seeing a patient with hypervigilance, hyperventilation, jumpy, easily startled, irritable. I mean, some of these overlap with a lot of different other issues. So you can tease it out by doing a more specific instrument or assessment if you want to. But, social isolation, that's happening quite a bit right now. Fatigue, exhaustion, people not sleeping. I think I had a duplicate slide there, sorry. So when you think about trauma-informed care, you think about building safety and trust. So what I do when I'm training people on this, I'm telling people to introduce themselves to the patients. Introduce yourself when you walk in. Tell them your role. Why are you there? What is your goal of being there? You got to respect and be aware of that power differential. Ask permission before you do anything. And, try to provide them as much privacy as possible. And if you stay calm in the setting, then that might promote a sense of calm for the patient. Collaboration and choice. So to help facilitate these, you want to be able to allow the patient to choose interventions and the caregivers who are promoting a sense of control, and that will promote a sense of safety. involve the patient in the treatment plan. Observing the caregivers collaborate together in a way that fosters great care, helps the patients with trust, and be clear about who's involved with the patient's care. So you can take a moment to educate them and then ask permission if it's okay that we're consulting a different service. You know, we're working together collaboratively to help you with your care. Even if the patient's goals do not seem to fit with your values, this is important too. Seek to understand what's important to that patient. This is a big part of palliative care, is that we really go to a great extent to understand the goals and the values and what makes a person want to seek or refuse treatment, and what can we do to help with relieving any suffering by offering other interventions. So instead of saying, well, obviously this person has poor judgment, they don't want to do what I'm asking them to do, that's basically imposing your values onto the patient. So you want to refrain from doing that. And remember, I'm going through a lot of this stuff because this is how we train many of our folks here, and especially in palliative care. And I want you to think about, if you're giving care to a loved one, especially if they've had some sort of trauma, like a TBI, or they've got dementia or something like that, you know, I want you to be able to think about, if that person's in the hospital, these are the things that I'm looking for to make sure that she's feeling safe, he's feeling safe, that the patient can trust us. You know, these are the things that I want you to kind of understand. These are the human experiences of trauma. And, you know, in a hospital setting, in a home care setting, in a skilled setting, even at home, you know, so that's why I'm kind of going through these different parts of trauma-informed care. When we provide trauma-informed care, the patient feels empowered because they're participating in the care. They're also helping with making sure that we understand what's important to them. The caregiver feels empowered because they're doing better care. They're getting better patient outcomes. They're getting better patient satisfaction. And then we are, especially, you know, being a safety net hospital, the second part of trauma-informed care is universal human rights. So we use our knowledge about human rights and equity and liberty and equality and distribution and access to help frame how we support the patients, you know. And when you combine all those things, that it improves the healthcare experience for large. So this is a case example, not exactly actually from ECMC. So this was when I was brand new in the field. This was a setting in a home care agency. So the case is this, I'm just using Jane, it's not really her name. So she was a 76-year-old married female. She had pretty advanced vascular dementia. So she, neurogenic bowel and bladder disorders, when you are no longer really able to control your bladder and your bowels. So she was dependent really on caregivers. She was unable to speak, but she communicated with behavior. She required a Hoyer lift to transfer. If you don't know what a Hoyer lift is, it's like a little mobile crane you can have in your house to help move the patient from the bed, picks them up. You can swing them over. It's pretty safe. There are lots of different varieties. She was dependent on others for feeding, bed baths, things like that. And dependent on all IADLs. So IADL is an instrumental activity of daily living. So these are the things that are a little bit more complicated than, you know, just feeding yourself. This would be the sort of complex coordination of being able to go and get food and shop and balance your budget, and then cook the meals. So more sequential and complicated tasks. And the patient was receiving 24-hour care at home. So the problem that I saw was this poor lady had vascular dementia. her behaviors, this was how she was communicating, were biting and grabbing. She would pull away during care, and she would knock over the basin, other items nearby. She was tugging during transfers, and she really had poor nutrition. She had poor oral intake, and she did not sleep well. So, I mean, of course, she had memory issues and problem-solving issues, impulsivity issues, but those were not what was causing her trauma. What I witnessed, so I was actually asked to come in and take over the case for another home care agency. And what I saw was the care that the nurse was giving to the patient was in this sort of like take charge mentality, you know. The patient was historically provided and administered Resveratrol, and that is an antipsychotic medication that actually can chemically reduce behaviors. There was force feeding, she was in restraints, and so that other home care agency was discharging the case, and they asked us to take it over. So the trauma-informed approach here was really listening to what they want. So the couple wanted to stay together no matter what, at all costs. That was the most important thing. They were willing to do anything. So when we took a trauma approach that really was centered on that couple, that man and wife, you know, how do we intervene? We personalized the care plan, and we were able to actually reduce the medications. So what is important to this is, you know, when we looked at what was causing the trauma, we were able to say, you know what, the way we were providing care, that was being provided care, was not actually preparing that client, that patient. So getting to know the client before offering care is very important. You know, personal care is very well named because it's very personal. You know, it's there's a certain loss of dignity when you need someone to take care of you and wash you in private parts and things like that. So, you know, getting to know your client, even if they can't talk back, introducing yourself, getting to know them, helping them feel the principles of trauma-informed care, helping them feel safe with you, earning their trust so that, you know, when you have to provide personal care, that you've already made it a safe setting. So instead of using cold water, you think about using, you know, scented special wipes that might actually help the patient feel better. Setting the tone with music, thinking about what was important to her when she was able to communicate her preferences, and, you know, figuring out textures of food, figuring out different flavors, you know, what was it that we were going to help with, you know, because it was full care, full hands-on care, 24 hours a day. And when we worked with the family to figure out exactly what would help her to feel safe, we saw a major difference. She was not in restraints anymore. She didn't need to use any medications to suppress her behavior. It was really one of the most dramatic things that I've seen in my experience in home care and in social work, really, because it was so important to have seen what the opposite of trauma-informed care is, and how they were struggling, and then how we could implement a trauma-informed approach. And the outcomes just got so much better for the family because they were able to stay together, for our caregivers because they weren't being bitten or, you know, having to force feed or anything like that. So I hope this is a good example because you know, this is something that I feel really important in especially folks who don't necessarily have a voice or feel like they have a voice, because we can help anybody who doesn't have a voice to feel like they do when we provide trauma-informed care, and that's in any care setting. So I think that's pretty much it. I do want to give credit to Katie Weaver. She's a social work student. Well, she graduated in the spring, and she was able to prepare quite a few of these slides for me. She was, unfortunately, her learning experience sort of cut off due to the pandemic. In April, unfortunately, all of our students had to start with remote learning. And so this is one of the projects she worked on. I think she did a great job. And I just want to say thanks to her. I don't know if she's listening, but she deserves the credit. So I have a list of resources here that helped us put this together. I definitely recommend, if anybody's interested in learning more about trauma-informed care, go to the SAMHSA website. They will offer you quite a few varieties of resources and things. So after that, I can open it up to questions. Or Katie, what do you want to do here? Go into questions?
Yeah, we can absolutely go into questions. Thank you for your presentation. That was really wonderful. And thanks to Katie for putting that together. I'm sure that was a bummer not to be able to finish out. But we have actually quite a few questions here. But if it's okay, Thane, I'm going to start with my own. And it's going back to your PTSD assessment. So for folks who might be watching the live stream or who are watching the recording later on and looking at that and thinking, oh, I might fit that criteria, I'm wondering if you could speak a little bit about how people can get help, where they can turn, and what that help might look like.
That's a great question. So, you know, if you are identifying with those, then you know, I would think about the different factors of resiliency and see how you might start to try to put those in place in your own life, reducing as much stress and anxiety as you can. But there are, you know, different interventions like exposure therapy, things like that. There's an eye therapy that helps to kind of like reprocess how you construct your experience, your memory of that experience, the trauma experience. And there are a lot of really wonderful clinical social workers and other mental health providers that are trained in trauma-informed care and can help you. And I definitely recommend reaching out. My contact info's on here, and maybe on the website, I'm not sure. But feel free to reach out to me and I can help with linking to any of the services that might be most appropriate for you.
Thanks, Thane. And us at Senior Services are also available, and we're at 858-8526. We work with a lot of community partners to make sure you get the help that you need and that fits what you're looking for. So the first question we have from our audience is, please explain compassion fatigue. Are supervisors trained to identify it, and how does ECMC management support employees who may have it?
That is a very good question too. I wasn't really expecting this, but you know, what we're doing is, you know, I would say, of course, there's leadership from the top, right? So we get videos weekly from the executive management and the administration who pass down information and support and thanks and recommendations on how we can take care of ourselves during this period of time. And then I know that each different department has their own sort of way of supporting each other. Thankfully, I work on a very supportive team. It's in our name, palliative care and supportive medicine. So what we try to do is you can tell when one of your colleagues or one of your friends is exhausted or depressed or anxious. And so I think, you know, we have a walk-in clinic here where anybody can go. In fact, it's open to the public. It's the help center. So we can head over there if we need brief interventions. And there are also resources, you know, that we can be linked with EAP and occupational health and things like that. Free food happens. We get free food a lot too, so that helps.
Thanks, Thane. Next, we have a comment. This veteran, so the person who's writing the comment is a veteran, describes PTSD as the mind's response to a horrific, unnatural event.
Absolutely, that's exactly how I would describe it. I'm hoping that it was a female, right? I'm hoping that
Male.
person. Oh, okay. I'm sorry. So first of all, thank you for your service, and I'm so sorry that you had that experience. And I do, I'd love for you to reach out if you're struggling with how your ability for your sort of cognitive ability to process the emotional response has been challenging to you. There are some resources out there that I'd like to link you with.
Thank you, Thane. Next, we have two questions about the historical trauma and changing the genetics of its victims. This person is wondering, is there a specific study that supports that conclusion?
There are studies. I don't have it with me right now, but I do. I actually worked for a period of time for the University of Buffalo. We were integrating behavioral health into the primary care clinics and, of Native American nations, reservations. And I was working very hard to figure out how do we support and understand, relate to, and help intervene in those situations. And, we immerse ourselves in a lot of the research of historical trauma. And I came across how it is beginning to change the genetics. And if you want to send me an email, I would be more than happy to kind of uncover some of that research for you or with you. I don't have it handy, but I'd be more than happy to.
Thane, we actually have a couple callers, so can you just give your email, please?
Yeah, it's T as in Thane, and then Schulz, my last name, SCHULZ, at ecmc.edu.
Okay, thank you. Next thing is, what are your thoughts about the role of social workers in some city models that have police and social workers as teams? If gaining trust is a big part of trauma care, it seems that a social worker's knowledge and strategies could be invaluable.
You guys have really good questions, and these are not the easiest questions to answer. So I think to answer that question, I have to reflect on my own training, my own sense of resilience and confidence in my ability to intervene in an emergency situation. I have great respect for police and first responders. I know that that's not something that I would be able to do. I would not be able to go into an emergency situation myself without the support of the police or other kind of first emergency trained responders. That's just out of my scope of practice, and I think out of my personal confidence areas. So, but I do support, and of course we followed along with the social justice movements that we've seen over the past few months, and sort of maybe rethinking some of the models, right, of how do we intervene. And there are a lot of crisis-trained social workers and other mental health providers. So I think that coming up with a model that supports assessing the patient and coming up with the right intervention that's going to be effective, reduce violence, and help with kind of the safety of the situation. I think that that's a really important dynamic, that we have de-escalation instead of escalation. And there are a lot of political perspectives to take when you're kind of designing something like this. I think it's become quite politicized. So I think it's going to take a lot of discussion among the police stations and administration, in the Senate and the Assembly, trying to figure out how do we work together without alienating police officers, putting social workers who are not trained in danger, So there's a lot to think about that dynamic, and I have thought about it. My brother is a police officer, and my personal experience with this is, I went on some ride-alongs with him a while back, and he, we would race to the scene, and he would jump out of his car and race into a situation that I would be racing away from. And so my personal experience is tells me that there is a great need for police officers who also could benefit from psychology or from social work training as well. So if there's some kind of union or some sort of partnership that can be really fostered between them, so that it's not either or, it's both, right? So I'm not sure if I answered your question, but that's my meandering thought process, right? Until we can all kind of come up with a better program idea.
That makes sense. Next question I'm seeing is, can you have secure attachments with people outside of your family that can help to protect you?
Yes, I think that there is a level of attachment theory in most relationships, and I feel like the common sort of the commonalities are when you have a sense of trust with that friend, that partner, that you're able to support them in being independent and support them in understanding what their choice is and how to either receive care or receive treatment or work. I mean, whatever kinds of social relationship it is, being able to find commonalities and ways of supporting, and being that sense of security when something bad happens to your friend. I think that's the part of one of the most important parts of attachment theory to me, is that you're there to support whoever it is when you fail or when your friend fails, so that they know that they can go out and explore and learn and succeed. And if they do fail, then they've got support behind them. And that can be anybody in your spectrum.
Thank you, Thane. Next thing I'm seeing is, I'm very surprised by one of your first slides. I would expect that everyone has experienced trauma at least once in their life. Can you explain this a bit more? Can you measure trauma? Is one trauma worse than another?
So trauma is measured by a few different things. So SAMHSA collected data and built data sets, which are quite reflective of the population. I'm assuming that you're thinking that those numbers are low. And so a person needs to identify an experience as a trauma for them to report it as a trauma. So that's where those data are coming from. But, a person's response to the trauma is kind of what tells you how bad or severe it was for that person. And I don't think that we can impose our perspectives or our bias or our thoughts to say that one person's experience with trauma is worse or was worse than someone else's. I mean, we can see in symptoms of trauma, maybe that we can assess that someone's experience has been worse, but I don't like to impose my own perspective on other people. An example of that actually is recently when cases of COVID started popping up at higher rates here in Western New York, Governor Cuomo made some pretty controversial comments. He mentioned that Western New York didn't really go through the first wave like New York City did. And so I understand, in terms of population density, population of infection, rate of infection, deaths, hospitalizations. I understand that those are all proportionally much higher in New York City, in the New York City region, than they were here in the spring. But he was putting value statements into his comments about how Buffalo didn't go through the same wave. And I sort of took offense to that, only in the sense that, I remember when we were going through our first wave, and I had a really, I was quite afraid, because we didn't know so much about it. The patients that were in the ICUs, they looked the most sick I've ever seen anybody, so it was quite frightening. And, thankfully, I can say here in the hospital that we adopted a lot of policies to protect our workers, the providers, caregivers, social workers, nurses, frontline, everything. And, the hospital was as clean as I've ever seen any hospital, and remains that way. So I think that by imposing his perspective onto our experience of the pandemic, I think that was kind of a problem, and my hope is that when you're dealing with somebody who has experienced something, that you don't impose your values or your goals or your judgment over that person's experience, because it's individualized. That's one of the points of this training, is that it's a human experience of trauma. It's not just a de facto or discrete experience.
Thank you, Thane. We're at 3:02. I have a couple more questions. Is it okay if we finish up, or do you have to go to do something else?
I can answer more questions, yeah.
Okay, thank you. So we have developing trust in long-term care is as important as demonstrating confidence at point of injury, ambulance, or trauma bay. Great case study.
Yes, and I think it has to be done in different ways, at different points of service. And we have to assess the level of acuity, right? So how acute is the situation, and who's the patient that needs that care? That seemed more of a comment, honestly, than a question, right?
Yeah, it was. Next, we have a comment. This was a very helpful session for those who have suffered from trauma.
Thank you. I was very happy to hear that. That was my whole point, right?
Perfect. Next, we have, can you define compassion fatigue? I don't think that everybody knows what that is.
Well, so this isn't something that I've studied specifically, but it's something that I've experienced myself. Compassion fatigue comes from when you are working with a population or working with some sort of disease, population health problems, mental illness. Or if you're the caregiver, honestly, the caregiver is probably the best. So caregiving at home, there are like $400 billion worth of caregivers that are not getting paid right now. So that's a lot of what we call informal support, which I think is a terrible name, but that's what it's called. So you've got a lot of folks that are caregiving at home. And so that compassion fatigue could kind of manifest in feelings of anger toward the person that you're actually caring for, even though you love them. And then, because when you're the caregiver, you're giving up a lot of your own time, you're giving up jobs, cars, money to go out to nice restaurants, things that are important to you. And so you may actually start feeling frustration and fatigue and anger. And then what's kind of awful is when you start realizing that you're feeling angry at the person that you love, you start feeling guilt for being angry at them, you know? So it's this sort of like cycle of how patients can cause the caregiver to kind of break down and collapse. You know, we see this when there isn't really enough other support, or, you know, like, it's emotional exhaustion, it's physical exhaustion. When you have to use a Hoyer to move somebody from a bed to the chair or to a wheelchair or something like that, you know, it takes a lot of work. It takes a lot of work to provide personal care. It takes a lot of work to be in the hospital. I'll never forget during the pandemic when we first started, you know, taking care of the patients and visitation was restricted. ECMC gave us some iPads so that we could start video conferencing with the patients' families. And I remember, so, you know, I would go up to the patient's room and I would get the nurse and I would give the nurse, I would first off ask permission if the nurse felt comfortable going in, because remember, this is when we didn't know much about it. And there was a lot of fear, you know, fear of exposure. We were trying to limit how much PPE we were using by not sending new people. That's why we were trying to reduce the exposure of that patient. So we weren't exposing additional caregivers, and we weren't using extra PPE. You know, think about when this was April, you know, so we got to kind of take ourselves back. And so I would give my iPad to the nurse who was going back in voluntarily to facilitate a conversation with the loved one. And that's not necessarily something that they're trained to do. So I was able to give them a lot of information, facilitation tactics and things like that, and how to offer support despite not being present. And I will never forget being so impressed with the nurses who volunteered to take the iPad, go in, start that conversation with the loved one, and be that sort of that link between the poor patients who may not be able to speak, or if they could, they weren't too acute. You know, that was very supportive for the families and the patients. And so, you know, I put on some rubber gloves when the iPad came out, and we have wipes that, you know, sanitize, and I'm surprised that the thing still has a surface on it because of all the times that we kind of cleaned it. And I'll never forget the nurses being able to go in there and do that. And despite all of the other things that they were needing to do to care for patients. So I think compassion fatigue is, you know, and the resilience are kind of interesting, you know. So these nurses were very resilient, but I know that you've seen on TV emotional interviews with people who really have kind of reached the end of their resiliency. And I think that's where compassion fatigue sets in, when you feel like you've lost that sense of control over your emotional response. You know, because we all able to manage our emotions to a certain extent. And, you know, emotional intelligence is being able to regulate how you emotionally respond to your environment. And the better you can manage your emotional response, the more sort of like emotionally intelligent you are. And so I find emotional intelligence and resilience to be pretty related. And this is sort of my perspective. It's just my observation. Maybe I'll do a research study on it someday. But when that resiliency, when that ability to manage your emotional response, I think that's sort of an indicator that you're too fatigued or emotionally fatigued. So I hope that kind of explored my thoughts on that. And I want to just give you the caveat that I have not done, specific study on that.
Thane, I thought that was wonderful. Thank you. We have two more things here, if that's okay. Just want to be super mindful of your time, but we have a comment that says, normal humans run from danger, first responders and soldiers run towards it. Then I have a question. Can you talk a little bit about repression?
You mean psychological repression?
I would imagine.
So this is sort of a defense mechanism. Defense mechanisms are things that we do either purposefully or subconsciously that help us to prevent feeling sort of the emotional pain that might come from an experience. So I see this happen in the hospital quite a bit. So repression, is one of those self-defense mechanisms where you're able to hold back from experiencing a re-traumatization from an experience or a memory. And I feel like that's a bit more subconscious than conscious, but I think that there is a relationship between being able to develop that as a skill. And I would defer to, psychiatry to see, or psychology to really define what repression is exactly and how we learn, because there are different interventions. There's counseling, there's cognitive reframing, it's called EMDR, what the eye movements help to reframe how you process a trauma. So there are a lot of different sort of interventions and skills that you can develop. Interestingly, here in the hospital, we see other defense mechanisms. And obviously nobody likes to experience the pain. So sometimes we see people, it's called displacement. So this is where we have to be informed of the trauma that this patient or this family member has experienced, So sometimes, we can be providing excellent care for a patient or they are very angry or they sort of lash out at the caregiver. And so, what that does, and we talk about it quite a bit so that we keep focused on how we help these patients. So basically they're displacing their anger of what happened to them onto others. And in many cases, it happens to be a caregiver. So, that's sort of another example of a defense mechanism.
Thank you, Thane. Then I'm seeing a couple thank yous. One comment is, there are no fruit baskets big enough to thank all of those wonderful nurses.
Thank you. I appreciate that. And can I comment too? It's funny, the comment that the other person said about first responders and soldiers, it's true. It's absolutely true, because I'd be running the other way. I'd be there to support them all when they got back. But, some people just have that courage. And that's kind of what shaped my answer to the question about how do we form partnerships with police and social workers and things like that. Because I understand there's a difference in the type of skill sets that we're born with, that we hone, things like that.
I agree with you, Thane. And then we have a comment. Thank you. Great presentation. Carry on that good work.
Will do. Thank you very much.
So with that, we will end our presentation. Thane, thank you for everything you do, for talking with us today and having this conversation, because knowledge is power. We know more. We can help ourselves and we can help other people in our lives. And everyone who's on, we appreciate you. I will try to post this tomorrow or Wednesday. Thursday, and I hope everyone stays safe and stay well. Thanks again.
Thank you, everybody, for the wonderful questions, and Kate for hosting. You did a great job. And, again, I'd like to thank Katie Weaver. She was my student last year, for helping to prepare this.
All right. Take care.
Okay, stay safe, guys.